Xin chào tất cả các bạn. Hôm nay chúng ta sẽ tìm hiểu về những cập nhật mới tại Hội nghị Asco về ung thư tuyến giáp giai đoạn tiến xa, những đột biến trong ung thư tuyến giáp và các thuốc đang được sử dụng, cũng như các thuốc đang được nghiên cứu hiện nay. Bài trình bày sẽ được thực hiện bởi bác sĩ Maria Cabanelis. Cô là bác sĩ nội tiết về ung thư và chuyên điều trị về ung thư tuyến giáp. Chúng ta cùng bắt đầu nhé.
I want to just start by disclosing that I'm an oncologic endocrinologist. I'm not an oncologist. I'm not oncology trained. And I only treat thyroid cancer. So I cannot answer your head and neck cancer questions that don't entail a question about thyroid cancer. But I'm going to talk to you, I'm going to update you today on advanced thyroid cancers and the different targets that are of interest here. These are my conflicts of interest. Okay, so just as an overview so that people understand how these thyroid cancers develop, essentially we have two major cells in the thyroid gland, the epithelial follicular cells, which produce thyroglobulin, and then we have the C cells, and those produce calcitonin. Our tumor markers are calcitonin and CEA. These are neuroendocrine cells. And from and of course you get medullary thyroid cancer from those malignancies. The more common thyroid cancers are the ones derived from epithelial follicular cells, which are called differentiated thyroid cancer. We have the papillary, follicular, and Hürthle cells, papillary being the most common, and then follicular and Hürthle cell being more rare. These tumors then can become less differentiated as they acquire new mutations. So the usual driver mutations in papillary, for example, are BRAF, RAS, and then rare fusions that we'll discuss today. And as they become less differentiated, they retain those driver mutations, but then they get additional mutations, and they can then transform to poorly differentiated and then ultimately anaplastic thyroid cancer. So thankfully, these are rare cancers, but we do see them quite a bit at MD Anderson. And I'm sure you probably see at least one new anaplastic a year, I imagine, if you treat cancers in the neck. So this is the Tcga data for papillary thyroid cancer. It was published a long time ago, 2014. But what I want to show you here is that the predominant driver in papillary is the BRAF mutation. It's BRAF V600E. It's in 60% of papillary thyroid cancers. And then there are a number of other mutations listed here to the right. So in papillary thyroid cancer, we see Ret fusions, NTRK fusions, we see ALK fusions, we even see ROS1 fusions that are not listed here. They didn't have any in this data set, and also BRAF fusions. So what do we use to target these? Well, we have two main classes of drugs, the selective drugs and the anti-androgenic drugs. The top ones here that I'm going to go through are the FDA approved ones for differentiated and medullary. So we'll start with the Ret fusion and Ret mutations. Ret mutations are seen in medullary thyroid cancer, whereas the fusions are seen in papillary thyroid cancer, and then cancers that are derived from papillary thyroid cancer. So a poorly differentiated derived from papillary, for example, an anaplastic derived from papillary. There are two approved drugs. One of them was just mentioned, but the two drugs are selpercatinib and pralsetinib. We also see NTRK 1 and 3 fusions. And again, these are usually seen in papillary, poorly differentiated anaplastic. We have larotrectinib and entrectinib that are approved for these indications. And then we have the anti-androgenic drugs, which we have actually 4 approvals here, both for medullary and differentiated. So we have 2 in differentiated thyroid cancer, lenvatinib, sorafenib, 2 in medullary thyroid cancer, vandetanib, cabozantinib. And then a number of investigational drugs, some of which are listed here. So the most investigated are the BRAF V600E mutated cancers. So we see this in papillary, poorly differentiated anaplastic. Approval for ATC with dabrafenib, trametinib, but these drugs are not approved for papillary thyroid cancer. We also studied vemurafenib and encorafenib, binimetinib in papillary thyroid cancer with BRAF mutation. We can see rarely ALK fusions and ROS1 fusions, but none of these drugs are approved for for thyroid cancer. So before I go on, I just want to kind of go over the management of patients with metastases, because not all thyroid cancer patients need treatment. In fact, most of these patients have indolent disease. And so it's important to understand when you should start treating. So with differentiated thyroid cancer, we start by suppressing the TSH, because TSH is a growth factor for thyroid cells. And so we drive that TSH down by putting them on high doses of thyroid hormone. We can give them radioiodine if they're radioiodine sensitive. Mostly we observe these metastases and see if they are going to grow or not. We have patients that have, stable metastases for 5-10 years sometimes. The younger they are, the more likely they'll have these stable metastases. And then, of course, we can always go back to radioiodine if they're radioiodine sensitive. We give focal therapies. We can give external beam radiation, cryoablation. We can do surgery on metastases if we have just one that's giving us problems, and then bone remodeling drugs such as zoledronic acid and denosumab. And then if they are, if none of these work and they have clinically significant disease that's progressive or it's threatening an organ or causing symptoms, then we give targeted therapy. So it's important to understand that the majority of our patients with medullary and differentiated thyroid cancer metastases are actually not going to need systemic therapy, and can be managed with these other therapies. I do want to make sure that you understand that differentiated thyroid cancer is the only one where we use radioiodine and TSH suppression, not in medullary and not in anaplastic either. Okay, so I think everybody's well aware of sorafenib and lenvatinib for differentiated thyroid cancer. Lenvatinib is a much more potent drug that can sometimes come with problems, the potency of these drugs. And so both are FDA approved, both improve progression-free survival, but lenvatinib is definitely the more potent of the two. In terms of the ASCO update, I know this is very busy. I'm just showing you the poster here to introduce the topic of Hürthle cell. So this is a study that was presented at ASCO this year on Hürthle cell. And Hürthle cell is a very kind of a different beast. It's a rare thyroid cancer. It is radio resistant in most cases. And so actually PET scans are very useful in this disease because these tumors are usually FDG avid. And the widely invasive Hürthle cells are the ones that can have recurrences and distant metastases. The ones that are encapsulated with no angioinvasion or little angioinvasion are usually, those patients do well. But the ones that are widely invasive are the problematic ones. And recently we've really learned about this tumor, which is totally different from follicular and papillary. The behavior is totally different. And on a genetic level, it's also very different. So we see mitochondrial DNA mutations in complex 1 of the electron transport. And this increases glycolysis, hence the FDG avidity. We also see loss of heterozygosity across many chromosomes, and that leads to a near haploid state. And this causes overactivation of the PI3 kinase signaling pathway. So it gives us a clue on how we can treat these patients other than using VEGF receptor inhibitors. We also see somatic mutations, although a lot of these patients don't have any mutations that we find. Unfortunately, these somatic mutations that we do see are usually not actionable. So DAX is one that we see more often, and then NRAS, NF1. A lot of these patients have just P53 mutations, and so none of these are really actionable at this time. Going back to that poster, this was an alliance study that Eric Sherman from Memorial Sloan Kettering presented, and basically randomized patients to sorafenib versus sorafenib plus everolimus. Now, everolimus had been shown to have some efficacy in very small trials in Hürthle cell, and it made biologic sense to use an mTOR inhibitor in this disease, and so. Unfortunately, it took a very long time to enroll just 34 patients. But anyway, because of the difficulty to enroll this study, they're not going to go on to a larger study. So this is the data basically that we're going to have. And essentially, you could be pretreated. So some of these were a bit unbalanced because 12% of the previously treated patients were in the sorafenib arm versus twice as many in the sorafenib everolimus. And he tells me he's not sure how that happened because they were stratifying by previous treatment. But anyway, what you see here is that the responses are really not different. A little bit higher with sorafenib alone versus sorafenib everolimus. But you look at progression-free survival, and it is longer with the combo, 24.7 months and then 10.9 months in sorafenib. But this was not statistically significant. Just probably these are just too small numbers. Okay, so moving on to another anti-angiogenic study. This is with cabozantinib. And cabozantinib was approved, remember, for medullary thyroid cancer, not for differentiated thyroid cancer. So what they did here is that this was a phase 3 study where they were looking at patients who had progressed after VEGF receptor inhibitor targeted therapy, and then put them on cabozantinib. And because there were phase 1 and 2 studies that we did that showed that this was actually quite effective, and so they went on to do this phase 3 study, and they presented the data here at ASCO. And so this is interesting. I mean, they're obviously going for indication here. Essentially, patients were randomized 2-to-1 cabo to placebo, and this is the progression-free survival. You see that cabozantinib, the median progression-free survival was not met. About 55% are free from progression at 1 year. And then in the placebo arm, the median progression-free survival was 1.9 months. And so this study was actually stopped early at the interim analysis because they'd already met their primary endpoint. Responses, though, were really not too impressive. Objective response rate in cabozantinib arm was only 15%. Majority of patients having stability, 69%. But these do look, promising, especially after lenvatinib failures. We don't know how many patients were actually stopped on lenvatinib just because they had adverse events, and then they progressed, and then they went on to cabozantinib. So that could be a problem for this study, and so it's just this one caveat. So their conclusions was that it improved progression-free survival, and the response rate favored cabozantinib, although it was not statistically significant. Adverse events were as expected. So why not just give everybody anti-angiogenics? It's easy. You don't have to have any mutation data. Just throw one of the anti-angiogenics at them. And this is the reason. So there are some relative contraindications: poor cardiac function or recent myocardial infarction, uncontrollable hypertension, large unhealed wounds, history of colitis or diverticulitis or bowel surgery, because these can cause perforations, tumor invading the trachea, esophagus, great vessels. We've seen carotid blowouts. We've seen TE fistulas, hemoptysis from or use of anticoagulants, and then very low body weight, because they do cause a tremendous amount of weight loss, except for vandetanib that causes weight gain. Probably some is just edema. So really, anti-angiogenics aren't safe for everybody. They're safe for many patients, but not for all patients. And we need alternatives. Also, patients eventually start to progress, and you may need an alternative for that reason. We can also use lower doses of these anti-angiogenics. You don't have to start the FDA-approved dose. In fact, that cabozantinib trial that I just showed you, they started with 60 milligrams, which is now what most people use. Okay, so what are the other targeted therapies that we can use? We talked a little bit about BRAF mutations, BRAF V600E. We've got the BRAF inhibitors. We have NTRK inhibitor for NTRK fused disease, Ret inhibitors, and ALK inhibitors. So let's start with the BRAF inhibitors. I'm going to talk about this in relation first to anaplastic thyroid cancer. So this was approved based on a small trial. This was a global trial. Remember, ATC is very rare, and then, of course, it's only about 35% of ATC patients that actually have a BRAF V600E mutation. So, and then it was really hard to enroll the study because patients had to swallow, and most ATC patients, I'd say about 40% of my patients really have a hard time swallowing because their tumors are so large. But great responses, 69% response rate, overall survival 80% at 1 year. We updated the data at ESMO in 2018, and we're now working on a manuscript, and the median overall survival is 86 weeks. So really good results. And so this is what we use as our first line in ATC. Just because a picture's worth 1,000 words, this is these drugs work very, very quickly in ATC, and so you can actually prevent putting in a tracheostomy if you can get the patients treated in time. So this patient was transferred already to MD Anderson with a tracheostomy. You see at 4 weeks, the skin has completely cleared up. We use BRAF inhibitors in the neoadjuvant as neoadjuvant in ATC because eventually all these patients progress. It's almost like as fast as they respond to these drugs, they also progress more rapidly than our papillary thyroid cancer patients. And so, in order to prevent catastrophe in the neck, we take out the tumors and then oftentimes we'll radiate if they have only stage 4B disease. And so we actually have published this. This was published in 2019. Our first 6 patients, we now have, I think, 30 patients that we've done this with. And basically, these patients oftentimes become resectable. I don't have the overall survival data here, but we have looked at our historical data with looking at overall survival in patients who were not resected but were treated with BRAF inhibitors, and those that actually went to surgery. And of course, there's some bias there; it's retrospective, but the difference in overall survival is quite striking. So a little bit about BRAF inhibitors in papillary. These are the trials that we've done. There are 3 trials. There were 2 trials, and you'll see the ones that are highlighted in yellow are the ones that were for papillary thyroid cancer. All of them are small trials. So this is one trial that basically had vemurafenib treatment naive patients and then previously treated patients. Progression-free survival is very good, 18 months in the naive patients. There was a dabrafenib plus or minus trametinib trial that didn't really show much difference in response rates or in the progression-free survival. And that manuscript is also in the works. Okay, so moving on to Ret inhibitors, this is really kind of the hottest topic right now. So Ret is a driver in many cancers. The most common one is medullary thyroid cancer, where we see, I don't know if it's 60%. This slide says 60%. I think it's a little bit high. Probably in patients that actually need systemic therapy, it's a little bit lower. Papillary thyroid cancer, again, the majority of these patients don't actually need systemic therapy. So even though we do see 10% RET fusions, the majority of patients don't need therapy. And then we see RET fusions in ATC and poorly differentiated. We also see this in lung cancers and non-small cell lung cancer. So they are very rare. Like I said, the most common fusion partner in thyroid cancer is CCD6, NCOA4, and TRIM33. But there have been 25 plus fusion partners described in thyroid cancer. The 2 drugs are pralsetinib and selpercatinib, and you heard a little bit about pralsetinib earlier, and I'm going to go over the data for both of these. So for selpercatinib, this was published last year in the New England Journal of Medicine. You can refer to that, but this at the time had only 55 patients that were previously treated with vandetanib or cabozantinib who had medullary thyroid cancer, and 88 patients who were treatment naive. And you see the responses down here, 69% for patients who were previously treated, so phenomenal, 73% for patients that were treatment naive. For RET fusion thyroid cancer, so this included the majority papillary, had some poorly differentiated anaplastic, and then this Hürthle cell. I'm not sure if that's just an oncocytic papillary or why this Hürthle cell would have a RET fusion. We don't usually see that, but sometimes they're mislabeled. The pathologist mistakes them for Hürthle cells when they're oncocytic papillaries, but 79% response rate. So really amazing responses in 19 patients. And this was a mixture of previously treated and untreated patients. At Asco, we have an update of this study, which includes a lot more patients. Don't worry, I'm not going to take you through this poster. This is just what the poster looks like. I'm breaking it down here for you for the important things. So in medullary thyroid cancer, we now have 143 patients. Remember, that was 55 in the publication of previously treated patients, and then 112 for the treatment naive patients. Response rate's still very high, 69%, 71%. In the RET fusion thyroid cancers, so they now break them down between previously treated which was about 77% response rate, so it's about the same. But then they broke out 12 patients that were treatment naive, and the response rate was 92%. So really kind of phenomenal results here. And I do use this as first line in my RET fusion patients. Adverse events, I just want to, there's a lot of questions about which one do we use since they're both approved. The adverse event profile is similar, but is not the same. I want to point out that, in terms of grade 3 hypertension, was fairly common, 21%. Increased AST and ALT were also grade 3s, were 8% and 10%. So some more hypertension and liver dysfunction with selpercatinib. So this came out actually the day after I gave my talk at Asco. I was so mad because I really wanted to have included this information. So this is like the first time I actually present this data. So this is the study that was just published in Lancet Diabetes Endocrinology for the pralsetinib study. We have here, this is, these are previously treated patients. Sorry, this label is wrong. This is RET mutated thyroid cancer. These are the medullary patients that were previously treated, and these are the treatment naive patients. And you see that very good responses, 60% in the previously treated, 71% in the treatment naive patients. For RET fusion thyroid cancer, very small numbers, only 8 and 89% response rate. Sorry, there were 9 patients and an 89% response rate. So really good responses, pretty much the same as what we're seeing with selpercatinib. But here's the kicker: the adverse event profile is just a little bit different. So for looking at grade 3 liver dysfunction, it's only 1% for AST and 1% ALT. And then this drug actually causes more myelosuppression. So if a patient comes to you and has received, 800 millicuries of radioactive iodine, I might be a little bit concerned about using pralsetinib in that patient because they probably already have some myelosuppression. So when you look at the grade 3 neutropenia, it was 13% and 10%. I usually check their for both of these drugs, I check their LFTs and their CBC 2 weeks into therapy. Essentially, this was what I was just telling you about the liver dysfunction, so I'm not going to go over it again. So I want to throw in a case here. I actually presented this one at ASCO, and this is a patient with vocal cord paralysis and shortness of breath. When he presented, had widely metastatic papillary thyroid cancer. He had a thyroidectomy. This guy had skin metastases, which usually, means really aggressive disease, but they had taken off the skin metastases. And so, even though he required 4 liters of oxygen, I went ahead and gave him radioactive iodine because most of these patients with RET fusions actually do take up radioiodine, and he had great uptake in the lungs. We identified some little bone metastases from this post-treatment scan. I tried to sequence his lung tissue, and no, he didn't have a BRAF mutation. The next generation sequencing had no mutations in DNA, but they were not able to do the RNA fusions. It was inadequate for analysis. So I sent in another specimen from his thyroidectomy, from his thyroidectomy surgery, and here we found a RET fusion, the NCOA4 RET fusion. So I observed him after radioiodine because I'd already given him the treatment. I wanted to see whether that was going to do anything. It really clinically did not make a difference. He was still requiring a lot of oxygen, and so I put him on selpercatinib. Remember, I had just given him radioiodine. So I chose selpercatinib because I wasn't sure if this, the radioiodine was going to affect his bone marrow on top of the selective Ret inhibitor. So I chose selpercatinib for that reason. And after 6 weeks of therapy, the patient felt so good. He was no longer on oxygen. Actually, we had to have a little talk because he had very bad hypertension. I told him to hold the drug, and he didn't do it because he felt so good. But we managed his hypertension and managed to keep him on the drug. Just to put in a plug here for this prospective trial, this is a neoadjuvant selpercatinib trial for for either RET fusion or mutated thyroid cancer that we're doing at MD Anderson, but right now only opened at MD Anderson. And so if you have a patient that has really bulky disease that needs surgery and you have a RET fusion, then this may be a good treatment for them. Okay, let's move on to the NTRK inhibitors in thyroid cancer. So the tropomyosin receptor kinase is expressed primarily in the nervous system, and therefore these drugs oftentimes have some neurologic side effects. And we have two drugs, entrectinib, larotrectinib. Entrectinib, aside from the NTRK inhibition, also inhibits ROS1 and ALK. And then just to let you know, there are second generation NTRK inhibitors in trial, and this we're using for patients who have failed these other drugs, entrectinib and larotrectinib. I'm only going to present larotrectinib because there's really only good data for thyroid cancer with laro. There's not a lot for entrectinib, and so I thought I'd focus on laro here. But for differentiated thyroid cancer, the response rate is phenomenal, 90%. Anaplastic, not as great, 29%. And actually, these are fairly short-lived responses. So here's just showing you the duration of response and progression-free survival and overall survival in all of the patients. But, the deaths here are driven a lot by the ATC patients. So adverse events for larotrectinib, like I said, a lot of neuro side effects. So we can get dizziness. It's like patients kind of turn their head and feel like the whole, everything around them continues to move. When they've stopped moving their head, they adjust to it usually. It does take a little bit of time, but we reassure them they'll adjust. Nausea, probably because of some of that dizziness. And then other issues they can have is fatigue, increased AST and ALT, and diarrhea. And I see a bit of anorexia too with this drug, possibly from the neuro side effects, the neurotoxicity. So just to show some of our data with NTRK and thyroid cancer, so the majority of patients have NTRK3 fusions. NTRK1 seems to be much more common in the pediatric patients versus, and then NTRK3 is more common in the adult patients. Of course, these pediatric patients grow up to be adults. And then just showing here on the right, the different histologies. So papillary thyroid cancer being more common, we see this more commonly. And then in ATC, we had only 6 patients, more commonly NTRK3 fused, and then a few in poorly differentiated thyroid cancer. We don't really see NTRK2 fusions in thyroid cancer. So these are the fusion partners. And the only point that I want to make here is that the common fusion partner for NTRK, for NTRK3 is ETV6. And most of a lot of our NGS platforms only test for ETV6. They don't test for NTRK3. And so you're going to miss some of these like TRIM37, some of these less common fusion partners, but they do make up about 60% of NTRK fusion partners. And so it's really important that you know what test you're getting. So this is an example of Foundation CDX. We see they test for NTRK1 and 2, but not 3. They check for the fusion partner ETV6. And so we will miss these other fusion partners. So which test do I think is best for fusions? In thyroid cancer, we use our homegrown one, but for the commercial ones, the Caris MI profile is very good, Tempus XT, and Foundation One Heme. And most people don't use the heme for thyroid cancer because they think, well, the CDX is for solid tumors, but there actually is an indication for solid tumors where RNA sequencing is desired for the Foundation heme. And then ThyroSeq is something that we use for thyroid nodules, but can be used also for thyroid cancer. Okay, so I have about 10 minutes left, and so I'm going to talk about immunotherapy in the context of anaplastic thyroid cancer. There's a little bit of data in differentiated thyroid cancer, but really the more interesting data is in ATC. Now, this is a study that was published last year in JCO, and had previously been presented at Asco meetings. And so we were really excited to finally get this in print. So this is 42 ATC patients. This was global enrollment. And the response rate in ATC for spartalizumab, which is an anti-PD-1, PD-2, was 19%, which, compared to other solid tumors is pretty much on par. But there's something interesting here when you start to break down the groups, which then granted become very small, that I'll show you in a minute, and that's the PD-L1 expression. I do want to say that there was only one partial response in a patient with a BRAF mutation. We do not use this as first line in BRAF mutated disease. We really need to use the BRAF MEK inhibitor combinations for these patients because the response rate is so good that we would never use this as first line, even with high PD-L1 expression. Okay, so these are the data I was referring to with when you break it down by PD-L1 status. And so you see any expression of PD-L1, and this is, by the way, this is the TPS, not CPS. So for using PD-L1 by the tumor score, right? Tumor proportion score. If you had any expression, your overall survival was much, much better than patients that had no expression. So, so really, we try and if we're going to use a checkpoint inhibitor in ATC as single agent, we want to be sure that these patients actually have PD-L1 expression. And so, and if you look here at the response rate, you also see a big difference. The higher the PD-L1 score, the higher the response rate. So 35% if it's 50% or higher. And then any expression, 18% response rate, but no responses in patients that didn't express any PD-L1. Okay, so at MD Anderson, though, we use a lot of combination therapies for ATC because, I actually used to be in the leukemia department as a hospitalist before, and so I had been trained in this mindset that you didn't use single agent in acute leukemias. You had to use combination therapies because these were very rapidly, they had rapid turnover and rapid resistance. And it's kind of the same thing in anaplastic thyroid cancer that we realize is that these patients are going to break through these drugs rather quickly. And so in many years ago we started adding immunotherapy to targeted therapy, and we started seeing some responses. So this is response after progression on the kinase inhibitor when we added it to the kinase inhibitor, so used it in combination. And so now we're studying and we practice this upfront immunotherapy plus targeted therapy in anaplastic thyroid cancer. And essentially, this is our clinical trial that just recently closed, but we broke patients down by what their driver mutation was and then put them on different therapies with atezolizumab. Our next study is going to be lenvatinib plus pembrolizumab, which we hope to start soon, but of course but we hope that it will be open this year. Okay, so in summary, for anaplastic thyroid cancer, molecular targeted therapy and immunotherapy are efficacious. We do see a lot of resistance to targeted therapy, and therefore we try and use neoadjuvant approaches when we can. In differentiated medullary thyroid cancer, please remember that most of these, even when they are metastatic, are indolent and they don't need systemic therapy. Usually the younger patients are the ones that have more indolent disease. Older patients start to have more aggressive disease. And usually you can tell who those patients are going to be because they have more than one mutation. When you look at their molecular profile, they usually have the more aggressive patients usually have multiple mutations, like BRAF TERT or BRAF PI3 kinase. Those patients usually do end up on systemic therapy. We remember to always evaluate for the possibility of giving these patients radioactive iodine if they have differentiated thyroid cancer, and then TSH suppression localized therapies. Consider molecular testing in patients who are going to need systemic therapy in the near future, and be sure that you know what you're getting. And then be sure to evaluate what the risk benefit is with anti-angiogenics. We are very careful with giving these to patients who are like vasculopaths, and we know are going to have problems, cardiac problems, or patients who are at risk for tracheoesophageal fistulas, or have disease encasing the carotid. And if you do have that risk, then I would either, to see if there's something more targeted that you can use, or you can use a lower dose, a reduced dose of the anti-angiogenic drug. So I thank you for your attention today. And I realized this morning when I was doing my final slide here that it was Juneteenth. So happy Juneteenth.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã chú ý theo dõi. Nếu thấy hay thì hãy đăng ký kênh của mình để theo dõi các bài học tiếp theo nhé. Xin chào và hẹn gặp lại.